안녕하십니까, 허인식 원장입니다.
Greetings, I'm Dr. Ho-In-sik. The online master course is a summary of offline master course. Today, I'm going to talk about incision and suture for soft tissue preservation. The contents of the day. There are 4 topics. First is the purpose of incision and suture. Second is about ideal incision. Third is about ideal sutures. It's like a needle and thread. Fourth, I'm going to talk about how basics is most important in incision and suture. First is incision and suture's purpose. There needs to be a clear purpose. What is the purpose of incision? The purpose of incision is to open flap and to provide the desired treatment in a smooth manner. That is the purpose of incision. You need to look clearly. Therefore, we need to think in the concept of optimum incision rather than minimum incision. We need to think creatively. We need to be able to provide the desired treatment in a most effective and swift manner. This is the second absolute principle. No matter how well done, incision interrupts the blood supply of tissue and it causes shrinkage of such tissue. The absolute principle in designing incision is to minimize interruption in blood supply. That is the design we need to look for in a creative manner. The purpose of suture is to get primary closure and to restore blood flow as much as possible. Incision and suture always go hand in hand, like needle and thread. Then, what is ideal incision? Let's talk on this topic. First, we need to understand the different blades that are used. In general, 3 different blades are used. The first is number 12 blade, second, number 15 blade, and last is 15C blade. Number 12 blade is used frequently in periodontal surgeries when the patient has natural teeth. Because it's shaped like a sickle, it is favorable in making mesiodistal incision in the gingiva. In the case of fully edentulous case, and when we open flap and place implants, number 12 is pointed, so it's inappropriate. Number 15 blade should be used. In the case of number 15C blade, when we do free gingival graft or connective tissue graft, this blade is most appropriate. Therefore, when we graft soft tissue, we use this blade. Ideal incision method. In talking about this topic, the blade holder looks flat, but personally, rather than a flat blade holder, I prefer round blade holder because you can get better grip and incision can be made more freely. Rather than flat form, I like the circular blade holder. That is my recommendation. When using the blade, you should not use the pointed area, but rather use the surface. This method is recommended. Another important point, when you make incision, you need to make the blade direction come towards you. You need to make a habit out of this. If you do it the other way around, in doing suture and incision, there is high possibility of medical accidents occurring. If you're unable to control the amount of force that is applied, or when you do suture, you might end up losing the needle inside the mucosa. This is a major medical accident. Therefore, please make sure that you use these tools towards you rather than the other way around. The blade that we use for incision, it needs to be new every time. Now, in the case of number 15 or 15C, even if you use once or twice, the blade becomes more blunt. You need to use a new one. If you take a STEM image, incision made with sharp blade is clean, but if you have used the blade multiple times, you get this kind of messy result. If multiple strokes are used for incision, healing will not be favorable and there will be a higher possibility of graft or membrane being exposed. Therefore, you need to practice so that you can make the incision in one stroke. Ideal incision method means that you need to avoid immature soft tissue or bone defect. In this case, it hasn't been long since extraction has been performed and immature tissues surround it. You can see that the defect is quite extensive. In this case, if you make incision like this, it will be quite unfavorable in doing flap reflection, grafting, and suturing. We need to avoid these immature tissues. When we make incision, we need to avoid anatomical structures such as blood vessel and nerve. In the case of free gingival graft, when we make an incision in the premolar area, there is a possibility of contacting the mental foramen, so you need to be aware of it. You need to check whether important anatomical landmarks are near. In the case of upper, when doing connective tissue graft or free gingival graft from premolar to molar area, this region is where we take the graft. Greater palatine artery passes here. If you make incision too deep or if you don't pay a lot of attention, excessive bleeding can occur and you can get caught off guard. You need to check whether the palate depth is shallow or deep. You need to check whether it is high palate or low palate and look for anatomical structures. Incision. We need to perform in keratinized tissue area. Why is this? Because there's not that many vessels, it's favorable for bleeding control. Because it is made of harder tissue, primary closure is more favorable. If you make incision in mucosa, the tissue thickness is thin and it's flabby, therefore there's higher possibility of failure in primary closure. If possible, you need to perform incision and suture on keratinized tissue. There's horizontal incision and vertical incision. The most prominent horizontal incision is crestal incision and palatal-sided incision. There can be buccal or facial-sided incision. Just because it's inclined towards one direction, it does not mean that it's palatal-sided incision. As shown, when the flap needs to be reflected, you can do beveled incision. The principle in doing a vertical incision is to secure releasing of the flap. You need to make incision beyond mucogingival junction in order to release the flap. Let's look at this case. After extraction, socket preservation is being attempted in this case. You can see significant granulation tissue in the extraction socket. In this case, what kind of incision should I make? Should I do it like this? No. In this case, incision line should avoid the immature tissue. That would be more favorable in doing flap management. As shown in the yellow line, incision line needs to be made. By doing this, you can preserve the immature tissue in the defected area and reflect the flap. Rather than just blindly resorting to palatal or crestal incision on keratinized tissue, you need to make creative incisions depending on the situations that you're in. You need to have this in mind. Suture has been done. Within short period of time, tissue healing has occurred. Third is about ideal suture. This is the needle used for suture. If possible, actually, you need to use a reverse cutting edge. The flat surface needs to be towards the top, so when you pull on the suture material, the tissue won't tear and it will be more favorable in getting primary closure. Otherwise, there's a high possibility of tear occurring in this area. As a result, I would like to recommend you to use reverse cutting type needle. This is strongly recommended. Suture material can be divided into resorbable and non-resorbable material. In dental field, resorbable material is rarely used. When doing a free gingival graft or connective tissue graft, or when forming bed, catgut is normally used. When we reflect a partial flap and use catgut at stitch out, you can minimize patient pain. But what is most frequently used is either silk or nylon. Personally, I don't prefer silk. I primarily use a nylon. I only use silk for extraction, and as for implant surgery or soft tissue management, in most cases I use nylon. Let me tell you the reason. In 2000, I placed an implant in this patient. I've used nylon 50 for suture. After suture, the patient did not return for 5 years. After 5 years, when you take a look, the suture looks transparent and there is plaque, but there is no inflammation whatsoever. Nylon suture has excellent preventative function against inflammation, therefore I prefer it. This is a recent case that I've done. After placing implant, soft tissue management has been done, connective tissue graft was performed, and for whatever reason the patient didn't return. The patient came back 3 months later. Take a look over here. Around suture, there's no inflammation. If I had used a silk suture, then a very serious inflammatory response would have been occurred. If graft had been done, it would have been more dangerous. When choosing needle holder, gold-coated needle holder is frequently chosen. I prefer needle holder with a small tip. In the case of interior area where intricate technique is required, I at times use a very expensive needle holder like Castro piezo type. The way to hold needle holder, there are many ways. There is very classic thumb ring finger grip. You put in the thumb and the rest of your fingers go in like this. This is most frequently used. The second is a modified thumb ring finger. You only put in the thumb. Some people use thumb index finger grip. They hold the needle holder in 90 degrees, and also palm grasp can be used. When you do surgery, actually, you intermix all these different methods. Therefore, understanding and remembering the name is not important. If you can do a good job doing suture, you can intermix all these 4 methods. It's not to say that you only stick to one method. There's also pan grasp. When doing suture, when you hold the end of the suture, the needle can be bent. Therefore, you need to hold 1/4. It is not ideal to put in the needle shallow. You need to enter vertically and make sure the suture goes in like this. At all times, the suture should be from mobile tissue to fixed tissue. From movable tissue to fixed tissue. The other way around is not allowed. Another precaution you need to take is that if you pull on the tissue excessively because of excessive tension, there can be necrosis. If you pull on it too tight, on top and below, if there's excessive difference in terms of suture, it's not ideal. This can be the biggest cause of flap necrosis. The knot should be away from incision line. It should not be on the incision line. If it is positioned like this, it can get in and interfere with primary closure. Last but not least, I would like to end off today's lecture by saying the basics are important. What is the absolute criteria that determines successful incision and suture? First, whether or not the incision and suture is successful is determined within a week. What are the factors that determine success and failure? This is restoration of good blood supply. You need to make incision and suture so that blood supply can be maximized. This is more important than anything else. No matter how good of a graft material you use or membrane you use, if the incision design is wrong, then it's all for nothing. If you look at this case, there was a lot of horizontal and vertical bone loss. Titanium plate and xenograft was used to do bone graft. Vertical and horizontal bone augmentation has been performed. After that, suture was done. What I want to show you here is this suture. Horizontal matrix suture was used. And there's the knot. And then in between, two interrupted suture was done. The role of horizontal matrix suture is to fixate the flap from below. Horizontal matrix suture allows for tighter and tension-free interrupted suture. When doing regenerative procedure, horizontal matrix sutures are used very frequently. The suture that I've used is 5.0 nylon suture material. In order to do successful regenerative treatment, you need to use a 50, 60, or 70. 40 and 30 are not fit for regenerative treatment. The prognosis cannot be good. In this case, horizontal and vertical bone loss was very severe. And I've used a titanium plate here and did bone graft like this. Membrane was used, xenograft was used, and suture was done. What kind of suture did I use? It's the same here. I've used the horizontal matrix suture to hold on to the bottom part, and a tight suture has been done. Two types of nylon were used. The 50 and 60 nylon sutures were used at the same time. Why do you think I did that? I've used a strong 50 in the bottom, and at the top I've used a 60 to provide an intricate suture. By doing this, you can restore blood supply, and such effect can be maximized. 30 or 40 causes too much of tensile force, so it can lead to flap necrosis. With a resorbable suture, it becomes loosened with time, so the flap can be reopened. The absolute criteria for successful incision and suture. The results are determined within a week, and the success and failure depends on blood supply. You need to have a design of suture and incision to maximize blood supply is the key. If you're interested in specifics regarding incision design and suture, please refer to offline master course. Thank you for watching.